Well, good morning, good afternoon, good evening, wherever you are located today. Thank you for joining us for this event all about exploring systems thinking in healthcare. And what we would like to do today is demonstrate through case studies specific ways that folks across the globe have used system thinking approaches and tools to bring some innovations into our healthcare system. And by looking at these case studies, we hope that you will learn about how to apply some of these tools within your own context. So that's the purpose for today. I'd like to take a few moments before we kick off with the conversation to introduce the team leading the event today. So there's myself and Marie Parent. I'm a volunteer with the SI Healthcare Hub. There's Josh, whom I'm sure many of you know, who will be facilitating this conversation. There's Rosina, who's my co-volunteer with the SI Healthcare Hub. And then there's Roma, who's also been helping us out a lot with this event. As a reminder, this event is 90 minutes long. There'll be some sharing of information, but we are very much hoping this will be an interactive sessions, which means we are looking for your input, for your insights, for your sharing of best practices as we go through this event. So to give you a sense of how this is going to run, we're doing a short intro now. We'll introduce you to the Canvas in a moment. Josh will take a moment to talk about some of these systems thinking concepts. And then Rosina, and I will talk to you about case studies. We'll take a few minutes to unpack those, and then we'll have a conversation facilitated by Josh to see what have we learned from this case study, how have they applied some of these principles, and maybe getting some of your ideas on that as well. And then we'll wrap it up. As we often do in these events, if this is not your first event, there's always this really interesting exercise we like to do around an icebreaker to help us see where you are located, because we do know these events attract people from across the globe. So if you want to grab one of the purple Post-its that you see below the map, and by the way, the link, Josh did put it in the chat for those who are just joining. So you can click there and go to the bottom left of the canvas we're using today. Grab a Post-it, drag it onto the map, and then write your name. And if you want to, share your LinkedIn link so you can connect with other folks that are participating in this event. So before I pass it over to Josh, just give you a few minutes to fill out the board, and then we will get started.
I see the stickies are 3 or 4 times as big in North America than in Europe. Is this a cultural thing we've got going on here?
Oh, I think mine expanded as I was typing text.
Okay. Well, this is a somewhat Westerner kind of meetup here, we might say. We've got some outposts in India, but aside from that, we're pretty much Westerners. Okay, Calgary is pretty well represented. Very well represented.
Oh, they're joining as a team. That's why. That's awesome. Thank you, Catherine.
Yeah, this map is obviously not an exact kind of science, right? Ireland is kind of part of England there, I think. But anyway. Okay, should we get started?
Absolutely. Go ahead, Jess.
Well, great to see all the participation today, and good to have you all joining. The team in Calgary and Anne-Marie in Quebec and others in across Europe here, and then Roma and others in India. So excellent stuff. Let's take a look at what we're talking about today. It's this big Miro board here with examples in the center, but on the left we're going to talk a little bit before we start about systems thinking and some of the key ideas there that we're going to try and explore and reveal through case studies and examples. We have 3 of those, as you can see here. And we'll be presenting on those, Roma, Rosina, and Anne-Marie, my colleagues in the Health Hub, and then we'll be discussing what ideas, what concepts, what systems principles we see in each of them as we get to the end of each one. But before we get started, let's just talk a bit about what we mean by systems principles and systems ideas. And there's lots of ways of talking about that, but this is one way of kind of breaking out key dimensions of systems thinking. And this kind of contrast between these 2 paradigms, the reductionist linear one on the left-hand side, or on the left at the top and on the right at the bottom, and then the one that's more reflective of systems thinking as we transition to the right there. So here we're talking about shifting from a partial to a more holistic view. Maybe I have these as I go down. Yeah. So this one's about shifting from not just seeing the parts, not just seeing the trees, but trying to also see the forest, which is a key attribute of systems thinkers, that we're able to actually kind of zoom in and zoom out, not just see the whole, but also then kind of zoom into the right place and be able to see the right tree and the right squirrel and all of this sort of stuff in the way that we need to. So be able to see the parts in the context of the whole and how the parts interrelate to form the whole is an amazing kind of ability that is often lacking. We get caught up in all the trees and walking our dog and all of this, and we forget about the overall forest. So that's one thing. And then how could that be used to really inform how we go about change and innovation in systems? And the idea is that we really need to at least have some kind of very crude view of the whole if we're going to start innovating on that level. So that's our first little principle there around trying to shift up just from the parts to seeing the whole and seeing the parts in relation to the whole. And Roma added a little example here. It's actually from our Health Hub paper, where we're talking about, well, what would that mean in the context of health? We hear very often that Western medicine and healthcare has evolved along a very reductionist direction over the course of the modern era. And we have that kind of painted here on the left. Healthcare systems are focused on the anatomy of the human body and ailments that can be treated through direct interventions that will create specific outcomes. And a more systems approach is actually looking more holistically, right, at the whole of the person, their psychological, physical well-being, their whole, social determinants, the whole context they find themselves in. And health is defined and constructed by the person's subjective experience rather than just the objective measures of performance and so forth. So that's just an illustration of it, shifting away from this parts view. I mean, healthcare systems are very good at kind of analyzing you and situations and finding that problem and trying to fix that problem, but not all complex problems, particularly chronic diseases, aren't really amenable to that approach. So we need to step back and look at the whole context. So that's one of these kind of shifts at the top left there. Shifting from linear to emergent thinking is another key one. You know, we often come up with this kind of cause and effect, problem and solution framing for everything. Works well if you're trying to fix light bulbs, but not if you have very big wicked problems with your healthcare system. Those are more emergent out of many different factors distributed across a network and the way they're interacting in destructive ways, negative synergies, leads to the emergence of these wicked problems. And we need to be thinking in that kind of emergent way, and not just the cause and effect kind of way. So actually, for the sake of time, I'm going to stay moving along. Hopefully, you're familiar with some of these concepts already. I'm sure you are. This idea of emergence, how small parts come together and form new patterns of organization. And it's a whole way of kind of looking at the world. So down here, we're going to try and shift from a more disconnected, compartmentalized view to a more relational, networked perspective of the system. And that's another dimension. So maybe looking at things like social networks instead of just the individuals all the time. What's their relationships between people, and what's the overall structures and patterns that form out of those relationships, and how are we influenced by those social networks and so forth that we form part of. And those can be hugely influential in this context, but if we take this kind of narrow view of the individual, we often lose sight of that. So it's another way of trying to change our thinking and look at things differently, and it can create huge another kind of approach for innovation, right? Thinking about social networks instead of atomized kind of individuals. Hopefully we'll see some example of that today. The last one's shifting from a more static and kind of planned view of the world to a more adaptive, evolving view. And it's an important one. Here we often think that we can predict and control, you know, very complex systems like healthcare systems, and we can plan them out, and we can do this kind of change management thing, step 1, step 2, step 3, when it can be much more beneficial to recognize the kind of nature of complex adaptive systems where we don't have this causality. We can't say if I do this, I'll get that. And long-term major change processes are more like evolutionary, widespread kind of distributed changes across a complex adaptive system rather than being imposed on it. We need to think about how to work with those kind of evolutionary, adaptive, iterative, experimental, often bottom-up kind of approaches to change. So those are some of the ideas that we're hoping to talk about today, hoping to see illustrated. Hopefully I'm staying on time here. And we can jump into our first examples, which is going to be you, Anne-Marie, isn't it? Yeah.
Actually, I am
It's Roma.
presenting first. So
Okay.
you could follow me, Josh. Thank you so much for that explanation of the principles, Josh. That was interesting. So the way these case studies are laid out is we'll be explaining one case study at a time, and then we will co-create a little bit here and have some discussion around this. So, and we'll have this after each case study. So here is the first case study about Bogota, based out of Colombia. It's called Bogota Care Blocks. If you want to read up more about it, you could press on this little button here and find out on their web. So this is a very interesting project because it centralizes caregivers. So Bogota's care blocks are city-led initiatives that aims to address the burden of unpaid care work, particularly for women, by providing accessible services and resources for both caregivers and those they care for with local accessible blocks. So this also aims to kind of bring gender equality and bring wellness to women who are actually caregivers. And this has applications in multiple, it is a multinodal kind of intervention. So that's interesting part of this. So the challenge here was that in the population of 8 million residents in Bogota, 3.6 million were unpaid caretakers, and most of them were women, with 1.2 million engaged in full-time care work. And turns out that most of them did not have access to education, like secondary school, 70% of them, in fact. And then 33% did not get time to take care of themselves. And then 21% have been diagnosed with illness themselves while they're also caregiving. Isn't that strange? And then 90% are low income, and most of them don't have time or opportunity to go out and work. So the way the care system was developed, this care system was to bring the city and its services to caregivers. And these services include professional and skills training, wellness promotion, and income generating activities. Services for care recipients include professional care and recreational activities. And then the care blocks are located within 15 to 20 minutes walk to most potential users. So it was not just skill building, but also the city itself, like city planning itself, went through a lot of changes. So that's the interesting part, like how multiple fields came together for this. So by integrating services from 13 city entities into convenient spaces located in densely populated and accessible city zones, these care blocks make it accessible for caregivers to take care of their own well-being while their loved ones are also looked after. So earlier, these entities were still available in the city, but they were not accessible either. They were too far apart, or they just made it accessible by working on the city planning. And then the new paradigm here is that the care blocks are based upon a new way of valuing informal caregivers and a new way of looking at care provisioning on that. So it places caregivers at the center of the policy and service delivery design, which is not seen usually, and then reorganizes the city itself to meet people's needs instead of the other way around. And then lastly, it addresses the inequality of the care burden from a cultural and societal perspective, thus ensuring long-term sustainable change. So these were some of the new ways of working in this project. And then the structural change is that care blocks work to decentralize caregiving rather than trying to improve the centralized formal healthcare system that recognize the informal caregiving that takes place in communities, and works to support this where it is rather than centralize it. So this, instead of like focusing on the regular healthcare system, they're focusing on caregivers, and that's really a very different way of looking at healthcare. And finally, multi-solving, like care blocks do not try to fix just one issue, which is like outcome of linear thinking usually, but are holistic in their consideration of many factors contributing to welfare of informal caregivers, while also working to improve the communities within which they exist. And also, if you read their website, it talks about how different stakeholders came together for this, including the government, academics, and a lot of different stakeholders work together to make this happen. They've had their own challenges during COVID, and they've worked around it together. And so this is about the project called Bogota Care Blocks. Over to you, Joss, for the next part.
It's great. Thanks, Roma. Yeah, interesting stuff there, but I'm going to leave you people to kind of unpack it now. We'll take a few minutes to post up ideas of what do you think's different actually in that relative to our normal way of doing things. And you can use this kind of a framework here, these kinds of ideas, but if you think something that doesn't fit in here, other ideas that you want to share, feel free to post those around the edges. But was there something around shifting from a compartmentalized to a relational networked approach, or a holistic, or this idea of emergence, or moving away from kind of planning to something more bottom up and evolutionary? You can choose the dimension you want or post up outside it if you think there are other concepts you'd like to pick up on. Let's take a few minutes, at least 4 or 5 minutes, to get your cogs working in your head and thinking about this and posting your ideas up, and then we'll come back to discuss those. If you have any questions, I will share the Miro board again. Hopefully everybody's clear with what we're doing at this time. And if not, I'm happy to help you. You follow the link in the chat and you grab a sticky on the side here and you post it up. That's a very small sticky, and we can make it a reasonable size like that and place it where we think relevant in one of these quadrants, if it's representative of those ideas, or outside, and tell us what you're thinking about it. Okay, let's take 4 or 5 minutes for that. Look forward to seeing what you come up to. Okay, we got a thumbs up here. So what are we talking about here? Let's done this first section. Actually, some interesting stuff. Care is not an individual responsibility, but a community level phenomenon. Who posted this? And what's it reflective of? I think it may be the same person who posted the other ones here. There's a realistic acceptance that multiple factors, problems impact the situation, and therefore the approach to change the status quo. Okay, so acceptance that multiple factors impact the situation. And this one here, by looking at other parts of the system, they look at a multitude of factors, saw how the system works and how it could be improved. We want to talk about this one? Connected to other things. So it's kind of about looking more broadly, isn't it, across the, not looking necessarily just inside the system, but outside of the multiplicity of factors and accepting the multiplicity of factors to try and get a more realistic view of the context and the reality that these people live with, and thus embracing complexity in some way. What do you think, Emery? What are you going to add?
Well, I was just going to add, I did add the purple one there. So often we think about care, we think it's limited to the health system and what we consider the formal parts of the health system. But it was interesting in this project how they broadened that around the community and the other parts of the community that supported care. So that it was broadening kind of more holistically what is part of that care system. So that's what I thought was interesting.
Yeah, I think a complexity approach almost always brings in the kind of informal aspects. We've ended up like through this industrial logic of focusing on these formal institutions, haven't we? And a whole pile of stuff gets excluded from that. Like in politics, we've left out all these social networks, haven't we? All these informal conversations and then they come back and disrupt us, you know. So I think complexity is about digging into all of that, kind of all that context and all those different factors that affect the situation. Okay, let's stay going here. So empowering the self-organization of informal carers, a bottom-up approach. Yeah, anybody want to talk on this one?
Yeah, I posted just this one, empowering the self-organization of informal caregivers. And I think what's important in this initiative is the empowerment of these informal caregivers. And by empowering them and putting them together, they can self-organize better. And therefore, emerging initiatives will happen by sure. And somebody else posted this one bottom-up approach, which I think is a good summary of what I meant.
Yeah, so instead of seeing them as selves as kind of deliverers of solutions to the end users, they're supporting the people who are doing the care. They're more like a platform for supporting others in organizing themselves, because they have kind of shared interest, don't they? These people who are taking care are probably taking care of families and so forth. So and the healthcare needs to take care of the system also does. So they're kind of finding a shared alignment, I think, and supporting the people who they should be working with instead of trying to deliver all that themselves. Layered application of solutions, individual, society, community. Anybody want to talk on this one?
Yeah, Josh. So my understanding was the solutioning has to be done from both the ends, right? One is that understand what community talks about from what are their needs, but also when they talk those things, those elements has to reflect at a policy or at a department level as well, right? So I think it has to be both ways. For me, it represents a hourglass, right? So the hourglass has to keep rotating. the content has to go both the ways so that you can the system evolves over a period of time. So I felt in the design at all the levels there was some sort of knowledge resource sharing so that the things came out as a system.
Yeah, it seems like they're getting better alignment, aren't they, between the kind of top-down institutions and the individuals in the community, when they sometimes aren't they're very disconnected, I guess, in many kind of systems. Great point. Thank you for that. Let's stay going. So down here, power divulged from care professional to informal caregivers. Gives greater chance of system adaptation. Anybody want to talk about this one? I think is a good example, isn't it? They're kind of pushing out to the edges the agency for these people to make their own decisions, to support them in making their own decisions and taking care of, the people they're taking care of. So that moves away from the idea that the institution has all the answers and shifts it to the people that they're supporting to make their own decisions about how to take care of these people. I think that's a good one. Let's stay going then. So caregivers, while unpaid, are critical to care and need to be connected to traditional systems. So we're thinking about, a more relational networked paradigm here. Interconnected different aspects of care and weave them as integrated response. Anybody want to talk about these ones? Rather than creating new services, it is inspiring to see what is available pulled together into a network. Yeah, so it's kind of working with the resources that are out there and kind of connecting into that better. Informal caregivers are connected through this new service. Yeah, I mean, potentially they're harnessing a lot more resources, the healthcare system, rather than just a few people who are part of the formal system. They can now tap into all these other people who care about taking care of, their family and whoever it is. So they're connecting into a much kind of larger pool of resources, I'd say. Anybody else want to comment on this one before we move forwards? Okay, Kim, do you want to share a little bit about what you're working on here?
I'm just sketching a little bit, playing around with that. But for me, I think the realizations I've done through a lot of research into understanding healthcare systems, and I think this is universally, is that there is a sort of the micro to macro sort of coherence, and the feedback loops between these levels are either broken or non-existent. And I think that's the issue, right? And several others have mentioned it, that we are not really, an individual is nested within a community or a city, and that city or that nation is nested within a country or the globe itself. And I think when there is, if I'm unhealthy as an individual, it can be many different reasons for that, but usually there's connection to certain elements of these levels. And I think to be truly holistically healthy, we need to connect these levels. And we just look at the climate, right? It's not healthy, and that's going to reflect us, and that's the macro level. So yeah, I'm just playing around a little bit, but I think for me that has been a big realization. If we want to have truly holistic healthcare systems, we need to work on all these levels, and we need to connect them and sort of have an intelligent sense-making system. Yeah, thanks.
The kind of feedback loops going, I think, is part of what's missing, isn't it? We're doing things over here that are, and fixing the problems over there, and things are very disconnected on different levels across different dimensions. But let's stay going. Maybe we'll jump into our second example here. And this is Rosina, who's going to share with us.
Yes, thank you, Josh. Yes, this is a project called Healthy Minds. and it's an intervention to promote mental health for youth and with youth, and it is being developed in schools. It's coordinated by the Living Lab for Health, which is a living lab where I work in Barcelona, in Spain. And of course, it responds to this challenge that is all over the world now, which is that mental health problems are getting worse. 1 in every 4 people will develop a mental health problem in their life, and 50% of these people will be under 14 years old. So we know also that it's getting worse after the pandemic. And for example, a study in my local context here in Catalonia, which is the region where Barcelona is located in Spain, 8% of students, almost 9%, every day or almost every day think that they would like to die or to go to sleep and never wake up. Despite suicide is the leading cause of death in young people, treatment coverage is extremely low, and there is a lack of sustained financing for services at scale. So we can see, as in the previous example, that there is a huge lack of service to attend this pandemic, which is this pandemic of problems of mental health. WHO have established a special initiative which is focused on empowering communities again. So creating these networks and also empowering individuals, but yeah, these different scales that we were talking about before. But the question is how can we empower communities and individuals? We realize then that there is a need for a new model. Most of current interventions are very fragmented. They target only some aspects of mental health. They are limited in time. So they appear in a school, for example, but then they disappear. And the user, in this case, schools have to choose, and sometimes without a professional criteria to know what is most needed in the classroom where they are teaching, for example. So we know that we need to move towards a more collaborative and systemic approach, but how should this approach be? So what we did was to design a new model for mental health promotion. And in order to design it, what we did was we conducted a participatory research project following a framework that is called a system-oriented dialogue model, which has these phases that you can see in this slide here, where we basically consulted teachers and students and integrated what they told us in order to co-design together with them the intervention. So if we go to the next slide, we conducted this co-design phase between 2020 and 22 with almost 2,500 students and their families and 23 schools. And we came up with a slide that is similar to the SDGs slide. So 17 systemic goals that we need to achieve in a school in order to have a school that is successful at promoting mental health. Of course, this is not easy, but at least it's useful for schools to realize that they can think about all these sustainable development goals, in this case, mental health goals, in order to prioritize and decide where they want to focus their intervention. So based on these results, we developed educational guidelines and also a repository of activities for schools to achieve each of the 17 goals. So here we were combining initiatives that already existed in a repository. So somehow creating a network of activities in the repository. And then these educational guidelines, what they do is this 3 steps process. First, students with their teachers, families, and also social actors conduct participatory research to identify protection and risk factors, and also to identify what they need. Based on this and the results of this participatory process that they conduct on their own, they identify the priority goals, and then they design and implement personalized action plans with the repository of all the activities. And finally, after they implement these activities, we evaluate what they did and disseminate the results of what they did in a congress at the end of the school year. And now to finish, therefore, this model has these characteristics that I summarized in this slide here. It's collaborative because it promotes the collaboration between different interventions that are in the repository. And it also promotes collaboration between students, teachers, their families, and also other stakeholders in their communities. It's personalized because based on the needs assessment that the students conduct on their own, they select the interventions that better fit their needs, and then they proactively implement these solutions. It promotes participatory research, which we believe is a high level of learning that also develops knowledge and therefore stimulates change better. And it's decentralized because students work autonomously, and therefore in different schools it can be scaled up easily because one organization doesn't need to go to all these schools, but they can self-organize. So now we are conducting pilots with almost 3,000 students in 30 schools. And when we finish these pilots, we expect to explore how to scale it up to even more schools than we are reaching now. And this is the summary of this intervention.
Wow, that's great. That's really, really interesting, Rosina. Thanks for sharing that. I was just wondering about the actual kind of framework itself. So you set out these kind of 15 or however many kind of areas that they could address, and then they work within that in terms of the things they want to do, or yeah.
Exactly. So there are all these 17 objectives, and for each of them, we identified resources that were already online in different places all over the world, which were developed by entities specialized in this topic. And then students can do the diagnosis, identify what is more relevant to them at this moment, and then select the initiatives or the activities from this repository in order to address the prioritized goals.
Yeah, that's great. I mean, I think you touched upon what's really is great is the decentralized nature of it and the kind of scalable aspect of it, because you're just introducing a bit of information, aren't you, in terms of some structure and ways of working and how they could go about it, and then they're co-creating the whole thing, aren't they? And why shouldn't they be the ones that co-create their mental health? It makes a lot of sense, doesn't it? They're probably the ones who know best about it. I mean, the people who are suffering, these are also the people who are suffering from it. So they should have a sense of what's needed also. Okay, great. Thanks a lot for sharing that, Rosina. I think there's some really interesting principles in there you touched upon. Collaboration is personalized, it's participatory, it's decentralized, and it's definitely co-creative. You're kind of creating a space, a platform for them to essentially create this themselves, which is, as you say, a very scalable, potentially very scalable option. So let's hear from you people. If we could take 5 minutes again to post up any ideas you have, whether they fit into the categories or outside, we would love to hear those. And I'm going to start the clock. We'll be back in 5 minutes to pick up on anything you have to say. Okay, let's take a look at some you've posted. 17 areas cover a broad range of the various issues and solutions. Okay. Identifying leverage points and rethinking the relationships within the system. Identifying leverage points. Someone want to talk about this? Anne-Marie, was this you? No? Anyone talk about leverage points? Where did you see those in that example?
Yeah, Jos, I think the goals that they have stated, I think the way they arrived at it, right? Thinking it of a multidisciplinary approach. And of the all the insights that they had, I mean, that's how they are at goals, right? These are the points which we shift, and then the system will be able to move in the direction that they want to move.
Mm.
So, and I think I felt it was a master move for two reasons. One was having 17 goals so that they're able to cover in multiple directions. And the other master move in that was by keeping it as a goal, you're constantly checking that, okay, if I have to achieve this goal, how is my current systems are placed, like how are my current loops, and are they really helping me arrive there? So already you're always having a North Star to go around, right? So I think that's where I felt those were the leverage points.
Did you have like a North Star to tie it all back to, Rosina? Is that, I guess, mental health was the main kind of overall thing you're trying to achieve, isn't it? Were you able to kind of tie those things together?
Which thing? Sorry, Josh.
So was there a sense of like what the overall objective was, being able to articulate that? Because you have 17 of these goals, like how they're fitting together to actually achieve the overall purpose. Yeah.
That's a good question. What we did was we distributed them as general goals and transversal goals, because if we look at them, some of them are characteristics of the process. How should the process be? So, for example, involve families. In order to promote mental health, normally most problems children have come from home. So it's very important to involve the families in the process, even if the problems are not from home, but they are key for solving the problem. So that's a characteristic of the process, and therefore what we did was to include that in the guidelines, in the educational guidelines, in order to guide the process with participation. And therefore we ended up with, I don't remember now, I think it was 8 of those that were the goals that they could select. The other ones they didn't need to select because they were in the process, yes or yes, so.
Integral monitoring, coordination with other health promotion challenges, impact on mental health, on learning and teaching, spaces, physical spaces, and emotional well-being. Okay, let's stay going then, not to get
Yeah,
caught up.
for example, physical spaces or responsible use of technologies, this one among the goals that they could select.
Great.
And what we realized is that most of the times interventions arrive and maybe they are very concerned about the use of technologies, but this is not the topic of the intervention that arrives, for example. So in that way, they could personalize it. Yeah.
Great. Let's stay moving on. Tripura, would you like to share what you came up with here?
Yeah, I feel like creating a network for the parents as well, to understand the students, what the issues are, and and also educating the parents, and so that on how can they support the students in the process is key, I feel. So having that network would help.
I wonder about network for the students also who are experiencing this, whether that would help a kind of peer network, but it might need informing by others too. But yeah, okay, co-creation with participants, solution focused on creating connections, the system adjusted around that. Anybody want to talk on this one?
I can so I think I wrote that one, Josh, and what it was is just by creating the spaces, especially around creating, co-designing setting up it just allowed the systems to go, oh, okay, and then people understanding each other, and then kind of solutions emerge out of those new relational connections that were created that maybe didn't exist before.
Or even looking at this whole thing as kind of a relational thing, like mental health is often a function of getting disconnected, isn't it, from the world,
Yep.
from people and so forth. And how can we take a relational approach in terms of asking about how can we reconnect this person with the things they need, the physical space, the people, the right context that's going to help them to regenerate, shall we say. So yep, okay, looking over here, a menu approach for students to choose. Okay, did they choose some of them, Rosina, or did each school just choose a few, or did they choose many?
Each classroom chooses the ones they want. Sometimes only one, and it's all the class that implement it. Sometimes they split in groups, and each group implement a different activity, and then they involve the other ones. Depends on the teacher.
Yeah, I guess part of all of it is this kind of idea of agency, like giving them agency to make choices and kind of create things instead of giving them the solution and the answer. Can be an important part of it. Okay, participating in the process seems like a great way for students to learn tools and to support their mental well-being, while that was also the end goal, dual purpose, journey and destination. Scalable and non-restrictive to location, allowing students to access what they need when they need it. Adapting to the changing environment and needs during the pandemic. Yeah, so this ran during the pandemic, did you say, Rosina?
It started during the pandemic because it started as a prevention method to prevent COVID in schools. And we realized that the problem that was most prominent at that time was mental health. So it started then, but it's now ongoing.
Great. And is it adapted? I mean, I guess that's what they were saying there. Did it change much coming out of the pandemic?
It didn't change much, no. Unfortunately, the problem is still there. There are some things that have changed because at that moment there were a lot of problems of communicating and meeting people with people, but these problems are still there.
Okay, great. Anybody else want to mention on these ones here before we move on?
We are also offering it in places where there are other small epidemic emerging. Like, for example, West Nile virus is now emerging in some places in Europe, which is a quite severe illness that it creates. And then we offer this in these villages where there is high stress because of this illness being transmitted through mosquitoes.
You probably need to work with some kind of authority too, don't you, to really get this started, or yeah.
Yes, we started with the government in our region. Yeah, and now it's a good idea to approach the city councils in the places where this virus is affecting. Yeah.
Otherwise, it can be difficult to get started. But great, thank you very much, Rosina. Let's
Thanks
move
to
on.
all
Yeah.
for your feedback.
Let's move down to the last one here. We've just got 20 minutes or so. We're going to hear from this final case study with Anne-Marie.
Yes, no, thank you, Josh. I thought this particular case study was quite interesting. And in this one, we'll talk more about a particular tool that was used to help with this system transformation. A bit like Rosina and Roma noted, a lot of additional information is available. If you go in the top right corner of many of these slides, there's a hyperlink that gets you to more information and tools you can use, including a facilitator's toolkit. But essentially, for those of you who've ever worked in a hospital over the winter season or the flu season, hospital usually brace themselves. They know that a lot more people will come in. They know that the hospital will be a lot busier. And most hospitals are also under significant resource constraints during a time where there's a lot of high demand for the healthcare system. So this particular organization in Fife, Scotland, they decided to explore how do we do this differently? How do we address this problem using a different approach? And to help them identify that different approach, they used a tool called the 3 horizons. I don't know how many of you are familiar with the tool. And thank you, Josh, for moving. Maybe if you just want to zoom into that chart. So essentially, when you were talking about 3 horizons, I'll just explain what the 3 horizons are and how you go about hosting that conversation. But first, there's horizon 1, which is usually the horizon of the status quo, how things are at the moment, how people are currently viewing kind of the situation or challenge. Then there's horizon 3, which is that ideal future of where people hope the system, should it kind of the expected system, like how do we think the system should be working? What's that horizon? And then there's the horizon 2, which is that disruption horizon. What would need to change to get from horizon 1, which is the current state, to horizon 3, which is the desired future state? And the reason why it's on a chart like this, so the people who kind of develop these tools, on the bottom part is kind of the time, and on the axis, so the x-axis is time, and then the y-axis is kind of like the level of attention or the predominant horizon at that moment. So initially, the way they view this tool is all horizons are always present. So there's always people working within one horizon, but they might be thinking about the other ones, and they're always at play. So it's not like there's a sequential, you're in horizon 1, moving to 2, moving to 3. All 3 ways of thinking and viewing the system are together, but one might take precedence over the other. So at the beginning, the status quo usually takes precedence. Then that disruptive way of thinking, horizon 2, might take shape. And then over time, the new horizon becomes that predominant model moving forward. So that's the 3 horizons worksheet. And there's a facilitator's pack, like I said, but here's how they use it in this particular scenario. They looked at the status quo and there was a lot of dissatisfaction. And then they were thinking about, well, how do we shift this system? How do we move it? And there's a short 3-minute video that demonstrates that through the conversation, they had a really powerful shift of starting from, instead of going to a patient and asking them, what's the matter with you? They shifted that conversation to a more patient-centered conversation, and they asked the patient, what matters to you? And this launched this project called Shine, which was meant to be a more patient-centered project. What is interesting is in year 1, they only had 6 patients who enrolled in the program. And the team felt like it was a bit of a failure. Like, wait, that's not a lot. And there wasn't any evidence that anything remarkable had changed. But they started listening to those patients. And for those 6 patients, being part of that shift and asking them what matters to you completely changed their dynamics with those patients. A bit like what we heard in some of the previous stories, those patients were now more engaged, involved in their care, more connected with their families, more connected to what needed to be set up for them to continue to receive care at home, for example. And so that gave a bit of momentum to the team to go, wait a minute, there's something in here, let's continue. So in year 2, they continued without any additional external funding. And in years 3 and 4, the results surpassed their expectations. They now had 5,000 patients enrolled in these programs, and they were now seeing more tangible results. And all of this started with a shift in mindset around, instead of asking them, what's your problem and how do we fix it? It shifted to what matters to you? How do we make this care process work? And the system kind of shifted around it. That's a really high-level interpretation of what happened, and I wasn't directly involved with the case study, but just from all the great information they have there. And I would just encourage folks to read it. They offered so much information freely around the process in hopes that others would benefit from it. So there you go, an interesting case study on how to change how care is provided in a hospital during a time of high pressure during those winter seasons.
Yeah, that's great. That's really interesting. I mean, it goes back to something I was saying at the beginning about we often look at this reductionist approach to healthcare, looks at things in kind of an objective way. Does what's wrong with you? Like, where's the problem here? Show me the problem. and many things aren't amenable to that, but they're shifting it to a more subjective thing, like what do you care about? What do you feel is wrong with you? Why don't you feel things are right? Which is coming from a very different place, isn't it? And it's a different paradigm. It's almost a different set of values in terms of shifting the locus. Because the locus is often like power and control, and everything's in the hands of the institutions, isn't it? And you have to fit into that. Tell us, like on this list here, which one of these problems do you have, and we'll fix it for you, right? And that's the normal kind of way. But they're shifting it to the locus being the person and how they experience their issue, and that can lead to something very different, kind of in terms of how you go about care, following from that. So. Fascinating. I mean, it'd be interesting to understand, more about what did come out of that in terms of then your approaches to working with those people. I might look into that afterwards. But yeah, anything more you want to say about that, Anne-Marie or Rosina? Yeah.
I think just in the shift of results, I think the care team, what I see, they were much clearer on what needed to be done, and the patients themselves were more engaged, like they were part of the care team, as opposed to I'm a recipient. So then they're like, wait a minute, maybe I can set this up. So it kind of alleviated burden just on the care team to try to find it, because the patient was also involved in that conversation. So just changing that dynamic of you are the receiver, we give you the service, is like, hey, we're working on this together. Here's what we can do. What can you do? And it just shifted the focus. So I think that had some impacts on the resources and the momentum.
And how you perceive it matters is what's being said when often that's not really recognized at all, is it? It's like we're going to figure out what the problem is and that's it, and it doesn't matter how you see it or anything like that.
Yes.
Okay, great. Let's jump in then. Take 5 minutes for you people, all of us actually, to have a think about that one. The three horizons in the Scottish healthcare system. I'm just going to put a little timer on. Feel free to post some ideas up. We'll come back and have a conversation afterwards. Yeah, feel free to go and jump into the resources. Also mentioned is that link at the top of the graphics here. So the YouTube video, the website and so forth there. There's also another video there and so on, much well documented and resources. So you're welcome to take a look at those as you're thinking this through. Okay, we're back again. Maybe I'll pick up on this one. Rachel, would you like to share what you're thinking here?
Yeah, hi, Josh. My point was like, as she was telling us about the different layers in the system, which are like H1, H2, and H3, and how the system was in a transition mode from H1 to H3, right? So in that, like how the system will change from a linear to circular thinking. Linear means we blame the single person for the mitigation error, and circular means the system has to be blamed actually. So in linear, we can blame the healthcare professional, but in the circular, we have to blame the whole system actually. So that was my thing, my thought actually.
Yeah, I think it's about co-created, isn't it? I mean, I think for me in this context, linear means that we think in this cause and effect way, but we also push out solutions to end users, these passive end users, and we deliver services to them and so forth. And emergent is maybe this co-created thing, or at least a good feedback between providers and users of the service, so that it's not just a kind of a push one way model, but circular and co-created. I'll stay going. So down here, patients and health providers work together, shared responsibility. Yeah, that's an interesting one. Shared responsibility. Anybody want to talk about that? Rosina, yeah.
Yes. Yeah, I think sharing responsibility is very important because we need patients to be more responsible, but with a paternalistic approach, we cannot educate on that, but we can educate with the example. So if we share this responsibility, then it's easier that the other one evolves in this direction.
Yeah, shared decision making helps both the patient and provider feel valued and like they matter. I think a lot of the challenge here is this thing of kind of reducing down complexity so that the centralized organization can deal with it, isn't it? Like so often they feel like they can't ask us questions and include us because that's going to create too much variety. They're going to want this or do that and so on and so forth. And that's kind of the way the system is set up, isn't it? So it's difficult to get, it actually needs quite a paradigm shift to get away from that, to get to something that is kind of co-creative where we can deal with the variety because people are part of it and they're part of kind of co-creating that. And then I think that allows for much greater variety, doesn't it? And shared responsibility and so forth. But I think that's totally true, that kind of sense of when we go into the system, we defer our agency to the system, and then we defer our responsibility and we defer our actions and everything to it. And that really dumbs down the capacity to co-create and, really work together and bring in more resources. So was this you, Rosina, who just dropped this one? Catherine?
No.
Yeah. Catherine, would you like to talk about this one? Arnold, if you're with us. Yeah.
Yes, we're all in a room together. I think we've heard about this for like at least the last decade and if not more. And I mean, all of this sounds great in theory, of course. And like so many of us, like whether we're designers or change makers, like working in the health system, at what point do we stop talking about it, and like what are some of the structures and systems that are getting in the way for this to actually happen?
And what's your take? Well, what's your take on that before we go to Anne-Marie? What do you think of the blockers? Catherine, I was going to pose that to you.
Sorry, our take on that. I don't know. What's our take, team?
What's the
I think Yeah, I don't like I think it's something, I think it's a big kind of question mark because I've had these conversations with folks for at least a decade now.
So-
Anne-Marie, you can jump in.
So we should have a session focused on blockers, is really what you're saying. Okay, Anne-Marie?
Yeah.
And Catherine, I'm not claiming I will have the answer. It's just kind of a perspective. So I haven't, fellow Canadian here too. I have not always worked in the health system. So I've only worked in it for the past since 2012. But the difference for me from shifting from other sectors is how there's a mindset in healthcare where everything is defined, right? Like every profession has its box, right? Of what's in your practice, what's not in your practice. And all of that has been kind of designed as if it's a machine and everything plays their part. And so I think what makes it hard is when everybody is trained like that, shifting a whole system. And a lot of these conversations are happening around what does it mean to be part of an integrated care team where there are some maybe clear lines, but there's a lot of gray. And same thing with now involving the patient. It's like we know this, but how have people been trained to kind of undo the mental building blocks of how the system was designed? I think those kind of like I think it's a shift at the kind of the mental model stage. And I want to use that term loosely because I don't think our mental models are so fixed. But I think there's a shift that needs to happen to understand what is my role in relation with the system, rather than, oh, this is the system, this is how it's structured, I do my part and the rest is going to work. So those are my observations of how to, and it's getting more people engaged in the conversation to see it, not just telling them, but you have to experience it to believe it.
Yeah, I mean, it's both, isn't it? Like we need to change the thinking and so forth, but then we have to go and apply that and deal with all those blockers and identify them and try and overcome them. So, but if we don't change the thinking first, we're going to go on, recreating the same patterns ultimately. Rosina?
Yeah, I think that we need to change the thinking, acknowledging that this is a transition. So we cannot pretend to change the system with a linear approach, just teaching or doing a 3 horizons exercise and realizing that that's the solution and then we apply it. It's an always evolving complex issue that requires a constant transition being managed by somebody and monitored by somebody. And what I've seen in other challenges, similar challenges, is that what helps a lot is when there are policies pushing for it. But there is a need also for structures to accompany the transition.
Yeah. Well, it's kind of a top-down, bottom-up, isn't it? I think policy is quite a top-down thing. But I think you need both, don't you? Okay, so we're drawing to a close here in terms of our time. Just these last couple of ones, moving from a framework where patients are the recipients to being able to co-design and create a solution that best fits their needs, adapting, evolving the plan based on participants, user interests over time. So. Yeah, we'll draw to a close now. Thanks very much for your contribution and participation today. Hopefully those three case studies illustrated new ways of doing things, right? And definitely sparked good conversation and brought up some of these really key topics and key kind of mental shifts that need to come about. But I think we have a topic for our next event already, right? What are the blockers to actually doing all this stuff in practice is a great one. I'm going to leave it there for now. Anne-Marie's going to draw us to a close, but thank you very much for joining.
No, thank you. So these close, just reminding you of how you can stay connected with us. So part of what we try to do is share knowledge around different practices. And a bit to answer your question, Catherine, like this is how we can create the change is by bringing different ways of thinking, and these systemic approaches can help with that. So to stay connected, you can join our hub. You can click there on the link if you're not already a member. There's a lot of information that we share there. You can also follow the LinkedIn group that would keep you informed about other activities. And as a reminder, all the sessions that we host are recorded and they are hosted on our YouTube channel, and you have the link for that there. Before you leave, what we do appreciate to help make these sessions more useful and helpful to you is let us know how would you rate the session by taking one of the dots you see on the screen and placing it on the scale of 0 to it was not useful to it was very useful, giving it a 10. And then while the rating gives us some information, what's even more useful to us is any ideas on how we can improve these sessions, giving us some thoughts. And so if you want to give us more details on one of the post-its at the bottom, this gives us a lot more richness to be able to advance and continue providing sessions that are meaningful to you.
Excellent. Thank you very much. Looks like the listing was for 1 hour, but we stayed here for 90 minutes. Apologies about that. Maybe there's a little error in the listing, but I think we needed the time and it was a great conversation. Actually, I mean, we should pick up on a lot more of this in the future and particularly how we go about applying it and the challenges to all of that. Any last words, Rosina, before we wrap up?
I just would like to thank everybody for all the reflection. I've also learned a lot, so thank you very much. It's been, I think, a learning process and I have enjoyed it a lot. Thank you.
Excellent. So we do appreciate, the feedback here is really, really helps inform, the sessions that we do and the hub that we develop. So much appreciated. And yeah, we'll wrap up there. Thank you very much for your time. Look forward to seeing you again at a future session, guys. Take care.
Bye-bye.